Okay, this one is for the Trinity residents. This was a patient who had a brain CT that had a large bleed, and they were doing a malignancy workup of the chest, abdomen, and pelvis. And you may have already seen a finding. It was basically in the upper abdomen in the liver. So what would you guys say about this?
So we're done. Brain bleed looking over malignancy.
Can you speak up? You said something concerning for malignancy?
Infiltrated. Yeah, there's some like infiltrated like hypoechoic all throughout the liver. Hypodense.
Good, excellent. So the borders are not that well defined. It looks very heterogeneous. It looks centrally necrotic. I was thinking like, oh wow, this is actually one of those times where the malignancy workup is positive. But they say that better than a smart radiologist is an old exam. And so we looked in the chart, and 6 years ago they had this exam, an MRI, and the lesion, you can see there is a lesion there, and it looked like this. So just based on this T2, do you have any ideas what this is? It's got a central kind of scar. Yep.
Large FNH.
Okay, no, tell me, one of your group or somebody else tell me why this is not an FNH. I like that we're going down this pathway though, because this is often what happens. People see the central scar, then they jump to FNH. Lots of things can have central scars. We should not hang our hat on that for FNH. Mets, hemangiomas, HCC, adenomas, they can all have central scars. Why is this
anything in the liver can have a central scar? I mean, this is I make this point all the time. Anything in the liver can have a central scar.
Yes, good. Okay, so residents, why is this not an FNH? Well, how should FNH look compared to the liver on T2? ISO, right? It's a stealth lesion, so it should blend in. At least it shouldn't be this bright. So the only things that are like really this bright is generally a cyst, which might be even brighter, like CSF, or what this is. Any guesses? I'll give you some more. This is the arterial, venous, and delayed.
Hemangioma.
Yes. So this was a giant hemangioma. And so I just thought this was a wonderful, interesting case where on the CT, it looked really heterogeneous and gnarly looking, and the MR kind of can clinch it. So if you have an indeterminate mass on CT, get an MR. And then when it's this bright, this well circumscribed, this is going to be hemangioma. When they're giant like this, they tend to have this even more T2 hyperintense central scar area, which is fibrosis. This area might never enhance. And that's fine. Even on the like extreme delayed, this is just not going to enhance, but all of this should kind of fill in. So this is just a giant hemangioma. Any questions?
Oh, good case.
Okay. Yeah, thanks for taking it. So this was a patient. I'm going to show you their chest CT in a few minutes. But basically, as we go into the abdomen, we can see that they have these large heterogeneous appearing masses. And they also ended up having a little closed loop obstruction, but we'll just ignore that for now. So these masses we didn't know what they were kind of indeterminate. You know, when you have bilateral masses, it didn't really look like, okay, maybe is one coming from the adrenal gland here, but, you know, be kind of unusual to have this, this metastasis if that was like an adrenal cortical carcinoma. We really didn't know what these were. We thought, you know, these could be Mets, they could be sarcomas, maybe a gist with a Met. We couldn't really clearly, it was abutting a lot of bowel loops. We couldn't really see it came from a certain one. And then this is what their chest CT looked like. Sorry, I'm still getting to know Sectra, I guess. Okay, so this is what their chest CT looked like. And basically we can start seeing multiple round pulmonary nodules in both lobes. here, here, here. So lots of small pulmonary nodules. This was a young female. And I will tell you that this process with these multiple well-circumscribed bilateral pulmonary nodules and abdominal masses was not metastatic disease, not malignant metastatic disease. Maybe that was a clue. Does anyone know a process where young females can get multiple pulmonary nodules? And I'll give you another clue. She had a hysterectomy.
Leiomyomatosis?
Leiomyomatosis.
Yes, good, excellent. So this is what is called benign metastasizing leiomyomatosis. So these are rare. It's usually in patients, young females who've had a hysterectomy for fibroids, and they don't really know exactly what happens, but there's some kind of leiomyomatous precursor cells in the lungs that then start proliferating with hormonal proliferation. And they end up being these kind of multiple, nodules. Like you have to biopsy these to kind of exclude. And in this case, she had an abdominal biopsy of this mass, and it came back leiomyoma. One of some discussion that we had in our group, somebody said like, well, how do you know that there isn't sampling error? Like this isn't a leiomyosarcoma, and you're only getting like the leiomyoma part of it. And an interesting tidbit that I've learned through through my pathologists is that leiomyosarcomas do not arise from leiomyomas. So it's not malignant degeneration of a leiomyoma. They come from a different precursor line. And so if you, like when you have a leiomyosarcoma, the whole thing is leiomyosarcoma. You're not going to see parts of it that are a leiomyoma or fibroid. So I think that's a little reassuring to say like, because otherwise you could say like, how do I know there's not a leiomyosarcoma hiding in every fibroid, right? And that tidbit is also really useful. Like if you have a classic fibroid or leiomyoma on an MRI, and then it starts looking differently on the next MRI, like it was T2 dark, but then it starts looking different. It is most likely just degenerating. It is not having malignant degeneration into a leiomyosarcoma. So this was just a cool case of benign metastasizing leiomyoma. Other interesting things you can get from fibroids are the invasive leiomyomatosis, where there's a benign fibroid that invades the IVC. And then also you can obviously get intra-abdominal leiomyomatosis, usually if they've had morcellation, and there's, parts of it that have been dropped all over the abdomen, which we don't do anymore. So, okay, I'm gonna pause. Any comments? Okay, so this was a prostate MRI, and we can see on the T2 weighted imaging that there is this ill-defined T2 hypointensity here that is at the apex, right apex of the gland. And it had restricted diffusion. Oops. This is not, let's see, right there. It was dark on ADC. So we ended up calling this PIRADS 4, and it was biopsied and came back Gleason 9. Interestingly, the patient then got a PSMA PET. Oops. Okay, so here's our PSMA PET, which was really useful because a couple of things came out. So this was a really high Gleason score, high risk prostate cancer. PSMA PET is very sensitive for prostate. And so actually it showed that some very small lymph nodes that were in the retroperitoneum were hot. So those were suspicious for nodal mets all the way down retroaortic in front of the bifurcation, as well as one here along the external iliacs. So, along the obturator here. So this was, there were multiple lymph nodes that were found on this PSMA PET. And then this was their next CT. And I want you guys to tell me what's going on here. So we're in the region of the prostate.
The urine and
it's a Space-OAR.
Yes, excellent. Yeah. So this is a Space-OAR gel. So they haven't treated the patient yet, but they were planning to do radiation therapy. And what they did was put a spacer gel between the prostate and the rectum. And we, in our group, at least me, I was used to seeing this on MR, where the Space-OAR gel looks like gel, like it's T2 bright. I'd never seen it on CT, and I wouldn't have predicted that it would actually look dense like this. You can see some of it is also kind of going into the seminal vesicle here, but it's nicely in the space between the prostate and the rectum. So does anyone know why it's dense like this? I'm gonna pull up the website for a sec.
What's your question, Aarti?
Why does the Space-OAR gel look dense like that on the CT? Because that was not what I was expecting. If it's just gel and it looks, T2 bright, why does it look dense like that? Okay, I'm going to just show you the website for the Space-OAR. This is like the brand. So on T2, it's nice and bright, and on T2, it's actually hyperdense. And they explain why on the website. They basically say they specifically put radiopaque iodine in the gel because they want it to be visible on CT as well. This can help because often when they're doing radiation, they're actually using CT when they're planning their field. So it helps the radiation oncologist because they use CT. It can be used when MRI is not available also, like you don't even have the MRI to see where your gel landed. This can streamline workflow. And then also it's for patients who might have metallic devices that can't get an MRI. So they made the gel kind of dual available, like you could use it using both MRI or CT, and they put dye within it so that you can see it on CT. So I just thought that was interesting, was not aware of that before.
So this was a pregnant patient. She was early second trimester, came in with chest pain, abdominal pain, and this was because it was a rule out dissection. We did sort of an arterial bolus. I know there are residents on this, and if they want to start mentioning findings. It's a chest, abdomen, pelvis, but I'll scroll through it because it is relevant. If the residents want to speak up, they can, or I can walk them through it. And I'll show lung windows as well before we go into the abdomen. Any thoughts so far?
You said she's second trimester?
Early second trimester.
I think the Trinity residents were going to say something.
We were gonna say on the CT we do see bilateral small fluid effusion, but however on the heart we do have pericardial effusion also.
Okay. And then we saw these slightly asymmetric to the right, ground glassy changes in the limbs with somewhat peripheral sparing. So looking at this, we thought this was more of an edema pattern. And heart looked a little big. There was moderate sized pericardial effusion. So she was hypertensive at the time of admission. So she came in at 190 over 110. So she was hypertensive. So we thought this was some kind of heart failure from sudden hypertension. And then in the abdomen, we have some other interesting findings. So there is perihepatic fluid. It was measuring a little higher than simple fluid. We even got it to measure close to 40 Hounsfield units. It's a very early arterial bolus, but the liver looked somewhat very heterogeneous in enhancement. Then a couple more findings as we go down. So that free fluid continues. And I'll window it a little bit. Subtle finding, but one of our residents made a great call. So
I saw something in the rectus sheath, like maybe
okay, we'll come to that. So the rectus definitely looks asymmetric side to side. So the left is asymmetrically enlarged, no history of trauma. At the time, the only thing that was low was her platelets. The PT-INR were normal, but she progressed to developing coagulopathy. And then there's a cute little finding here.
Gonadal vein thrombus.
Actually, this is arterial, so we call it a small dissection.
Oh, oh wow.
Yeah, it was a tiny discussion.
Oh, sorry. And it's not the gonadals. Okay.
Yeah, that's an RTP. So,
The low platelets was making me think of HELP syndrome, and then the
yes.
liver looked a little bit like cardiac congestion.
Yes. So we kind of said the same thing, and here's the sagittal on that. We were a little confused about this band-like constriction here, but we let it go as probably a focal myometrial contraction, which is something else that can happen in pregnancy. Braxton Hicks or pseudo contractions. She was very early to go into labor or anything like that. But so we attributed everything to pre-eclampsia-like spectrum with the cardiomegaly, developing cardiac failure, hence the effusions, pulmonary edema, and then low platelets, hence some coagulopathy, hence hyperdense fluid that was developing in the belly. And then probably coagulopathic also, that's why the spontaneous rectus sheath hematoma. And then hypertensive, hence the dissection. So we called all of this, and then unfortunately the next day what happened was she coded. And post-code, I'll show you the sagittal. So this is what happened post-code. So for the residents, look where the baby is now compared to where it was before, and what has happened to the uterus fluid. So baby is expelled out, right?
It's crazy. Uterine rupture with like active extravasation.
Yeah, all this was active extra.
Wait, Roopa, why did she code?
So we don't know, Victoria. So some things we were looking up in the literature, they said preeclampsics also have a very high incidence of spontaneous coronary dissections. So we don't know if it was an acute coronary event that precipitated this.
Oh, she survived?
She is, she's in bad cerebral edema right now. The baby, of course, died. So they had to do an emergency surgery, remove the baby. They had to do a hysterotomy and suture this back. They had to embolize a bunch of vessels. She's alive, but somewhat very non-functional. So very quick escalation of what started as preeclampsia. So for the residents, I just wanted to show a quick overview. So there's a very nice article in Radiographics. If anybody wants to read, I've attached a link to that.
Roopa, I have a question. So
Yeah.
the uterine rupture was thought to be, is that common in preeclampsia, or like what caused the uterine
It
rupture?
can, but in this case, I think it was induced by the code and the resuscitation.
Oh.
She had one previous pregnancy, so they said when they went in, the OBGYN said, they said it had ruptured at a site of previous C-section scar.
Wow. Okay.
I know. So things we need to look for. So she was only 18 weeks actually. So technically, apparently eclampsia or pre-eclampsia is at 20 weeks when you have new onset proteinuria and pedal edema and whatnot in a previously normotensive patient. It's actually mediated by the placenta. Placenta starts developing ischemia. And that's why, as a reflex mechanism, the blood pressure goes up. If they start having seizures on top of preeclampsia, then it becomes eclampsia. So for the residents, look for posterior reversible encephalopathy. If you have a preeclamptic patient, look for features of pulmonary edema, which our patient had. Her liver looked funky. We didn't see any focal infarcts. Look for renal artery stenosis. And in her case, she did have a cardiac event. We'll never know if it was a spontaneous cardiac event. And then HELP syndrome, like Aarti was saying, is when you actually go into coagulopathy and failure. It can occur in a good percentage of women with preeclampsia. And the pathology there is because the platelets are low, they bleed easily. And from all the bleeding, there is sinusoidal obstruction. So when the pressure increases too much, that area just undergoes infarction. It can decompress subcapsularly, it can cause hemoperitoneum. So this is Cookie's article from Radiographics. It's a very comprehensive review. And this is an old AGR one I found. So this is what the liver can look like when it's starting to get infarcts. Ours was not quite as bad. And this is when there's frank decompression into the subcapsular spaces and hemoperitoneum. So not a good outcome for the patient, but I know residents don't see as much. We don't image as many pregnant patients in CT. So this was kind of a nice learning case.
Yes, excellent. And most of the high-risk OBs will say that CT is okay, like after the first trimester, and especially, lower the dose as much as you can. But Okay, Victoria?
Okay. Okay, can you hear me?
Yes.
Sorry. All right, so this is not a liver. Anybody sees anything that's unusual or upsetting or? This is a high resolution T2 of anal sphincter complex, right? So this is the external anal sphincter. This is internal anal sphincter, right? This little.
There's something anterior to it, like around the urethra or in that space.
No, I think it's just a little bit of gel left over. All right, so this patient came in with a very specific problem. So this is the first run through high-res T2s that we done, and then we did this. You know, we have gel inside her rectum, and we ask her to bear down. So you can see some of the gel already showing up in vaginal like vault. So even based on these images, we know that there is some sort of vaginal fistula. But then what we did is we repeated the high-res T2s after she bared down, and ta-da! So now you can really nicely see the fistula.
Very nice. We do like these fat sat high-res T2s, like that I find helpful. Do you guys do that too?
So, okay, so this is all historical, right? Because I don't do these anymore, but we actually stopped doing T2 with fat sat because it was obscuring a lot of details of the sphincter complex. And, you know, for these are like, you know, when the fistula is large, you know, you can see it whenever. But for these occult fistulas, you won't see them often unless you do this gel and then vasalva. So I have a few cases where patients came in and clinically, you know, clinically there was suspicious for, you know, for fistula. So that's how we start doing them routinely for these indications. And often you will see nothing on the first run, and then after patient bears down, you'll see the gel outlining the what do you call it, the tract. As you can
Yeah,
see.
I love that, because our fistula protocol is not like we do the bear, you know, having them defecate on the defecography one, but not on our fistula protocol. So how quickly after they bear
Right
down,
away.
or like you're
Right away.
Okay.
It's basically modified defecography protocol. So we do the you know, high-res, you know, this is a Vista. I think it's Cube on GE, and I forget what it's called on Siemens. But on Philips it's called Vista, but they're all the same. It's like a 3D high-res T280 sequence. They're long, they're about 5-6 minutes, but they, you know, they don't have a lot of coverage. And you want to put them, you know, perpendicular to the plane of anal canal. So about slab is angled 45-degree anterior approximately. So you do the first run, then you have the patient do the defecography sequence once or twice, and then you do another run. And then if the patient has like functionally intravaginal fistula, you'll see it, because you force the gel out through the fistula and you see it nicely.
very nice.
Yeah.
In the high-res protocol for perianal fistulas, I think T2 fat sat is really important. Every article that we've read on fistula says that, and I'm talking of perianal fistulas, if they're specifically looking for a, you know, like a vesicovaginal or a, you know, fistula from the rectum to the vagina, I think doing what Victoria said is excellent. But that is the only indication where we are still doing fat sat T2s. And we do quite a bit of these cases, and it's really helpful.
That's been my experience too. I really like the fat sat T2s. So I guess we'll debate about it, but I guess Kedar and I are on the fat sat T2 side, and Victoria hasn't found it as useful.
Well, the problem is that I found that high res is more important than T2 fat SAD. And when we tried to do the Vista with fat SAD, it came out awful. So, and then T2 fat SADs, they always do them large field of view. It's never as thin of a slices as high res T2. You can't, it's not isotropic voxel. So these you can manipulate easily and angle exactly as you need to. And you can angle to follow, you know. So I also find that when you have this protocol, you can find the opening of the fistula much easier, because again, you can angle the slab perfectly because it's an isotropic voxel acquisition. So you can, you know, you're not losing any resolution. But with, you know, let's at BI, they love to do T2 fat SAD, and then you're at the mercy of, you know, the technologist putting the slab correctly, which is usually, you know, not there, and that's it, you're done, right? Whatever you got is what you got. And yeah. And
Yeah, I think this might be vendor specific, because we, our T2 fat SATs are, let's see, yeah, are high res, and same with at Arkansas, and we do it in the axial and the coronal plane, and I find that it's very, very helpful. So it might be
it may be gender. It may be vendor specific.
Yeah, cool.
Great.
Okay, thank you, Kader, for chiming in. And then Roopa, there was a request to share the link for the HELP syndrome article, if you can.
Yes.
I'll put it in the video too. Okay, I have another case. And I want the residents to take it. Just make sure I'm recording. Yep, okay. So, you guys see anything? Patient was having GI bleeding.
Large heterogeneous mass within the stomach.
Yep. Okay, so there's a large, avidly enhancing heterogeneous mass in the stomach. What do you guys think it could be? Somebody's chatting in, so I'll look at that too. Okay.
Yeah, looks like it's setting off the wall, probably. So I guess suggest maybe.
Excellent, excellent. So GIST would be like our top 1, 2, 3, right? Because gastric cancers usually grow like infiltratively. They don't grow kind of as a well circumscribed mass. This one is endophytic, which a lot of GIST can be exophytic or endophytic or both, but most of them have a predominant exophytic component. And I just want to point out one thing is that we didn't do a gastric protocol on this exam because you can see that the stomach is not very distended. And you really need to do that. You need to have your stomach distended with either water or volumen so that you can see where the GIST is truly arising from. Like here, I'm not sure, is it the posterior wall, anterior wall? Is it involving, you know, what's it involving here? So the patient had a repeat scan, and this is now with the gastric protocol. You can see that their stomach is super distended. There's some other stuff going on, just ignore that. But now we can nicely see the GIST tumor is arising from that posterior wall. It's not even involving the anterior wall at all. It's kind of got a long, broad-based stalk. And then a couple of important things for GISTs is you want to tell them if it's involving the pylorus at all, if it's involving the GE junction, because, and then how much is endo versus exophytic. I'm just going to pull up a little PowerPoint here. This is just from my GIST talk, but just wanted to show you guys. So the location will determine what they're going to do for GIST tumors. With large tumors, they'll often give Gleevec ahead of time if they have a CKIT or a DOG1 mutation, which is about 90% of GIST, because that can shrink it, so make the resection easier. If it's if it's exophytic, they could do a laparoscopic resection. If it's completely endophytic and smaller, they can endoscopically resect it. And then importantly, if it involves the GE junction, so they want to know how close it is, or if it's really involving that sphincter there. Sometimes if it is definitely involving that and they can't dissect it off, they might even need to do a total gastrectomy. This is usually more common if it's a gastric cancer and they need full oncologic margins, and then they're going to have to resect the vagus nerve, and then they might need to do a total gastrectomy. And then also, if it involves the pylorus, they might have to do a distal gastrectomy with a pylorectomy, which means that you can have dumping syndrome from the stomach dumping into the jejunum. So, and then there is this hybrid approach. So if it's partially endophytic and partially exophytic, our gastroenterologists and surgeons get together, and the surgeons will resect the outside, and then the gastroenterologist will kind of push from the inside and show them the margins. And so it'll actually, they basically do it in combination, and this will make their gastrectomy site smaller, so they remove less of the stomach. And then Roopa has shared the article. And then one more thing I wanted to show you guys about this GIST tumor. There is something cool called the GIST nomogram. So basically, it tells you what the risk of recurrence is. So residents, what do you think about this tumor? Do you think this is going to have a high risk of recurrence or a low risk of recurrence? Meaning metastatic disease, like in the liver and the peritoneum.
I have no idea. Just lower.
Just as someone
Just, you know, I heard.
Shock alert, emergency
I
room.
think the
Ready, room
consensus
three.
is less
Shock alert,
likely.
emergency room, Remy, room 3.
Sorry. I can hear a lot of background noise, but you think this is a bad tumor or a good tumor?
I would say probably a little bit better.
And why?
Mostly guessing, but I would, because it's so large and it hasn't already metastasized, I feel like that's a pretty good sign.
That's excellent. That's really good intuition. So our large, welcome circumcised, it hasn't become centrally necrotic yet. So it's not like so aggressive, it's outgrowing its blood supply. We don't see Mets yet, etc. But one of the biggest things that's helpful about this GIST tumor is that it's arising from the stomach. So stomach is much, much better than small bowel or colon. And then there's something called the GIST nomogram. Let me just stop sharing for a sec. Okay. So this is Memorial Sloan Kettering site. And basically there's a nomogram that shows you can calculate the survival without recurrence following surgery for GIST tumors. So you basically go to the GIST, you can just Google GIST tumor nomogram, and then you enter in your information. So my GIST tumor was 12 centimeters large. Its tumor site was the stomach. And the mitotic index was 3 per high-powered field, so it was not above 5. So it depends on the size, the location, and the mitotic indices. And then you calculate, and they give you this nomogram. And so this patient has a 2-year, 89% probability of recurrence-free survival, and 5-year, 79%. So this is actually really, really good, right? We can now, like now when we're doing our follow-up scans, and they'll actually put this in the pathology report. So now when we do our follow-up scans, we know that this patient, this was actually a pretty low risk GIST tumor, and this is going to do better. And then like, I'll just give you an example. Like say I had the same tumor, but I picked like the small bowel. Let's see, let's calculate that. Okay, so now their survival is going to be a lot less, 66% at 2 years. Victoria has her hand up.
Yeah, just want to this is survival post-surgery, right?
Uh-huh.
Okay, I misunderstood. Okay.
Yes. The one caveat I will tell you, I thought you were going to bring this up, is that if they've undergone Gleevec therapy, it is not as accurate to get the mitotic index after Gleevec because maybe you've killed off a lot of the tumor. And so the mitotic index may not be as accurate. On the other hand, if you're using a biopsy specimen from before you did Gleevec, that might not be representative of the whole tumor. So this is a general thing. Sometimes they will put a caveat in the pathology report that that's like, you know, because of the Gleevec treatment effect. So colon here was better, but because of the Gleevec treatment effect, the mitotic index may be inaccurate. But I find it really helpful. And the main point I was trying to make here is that even if it looks large, like the residents had the great intuition that like maybe this isn't even that bad of a tumor. This one actually had very low mitotic indices and was, you know, pretty intact and no Mets so far. So that's just called the GIST nomogram, and you can calculate it. And actually, they should be including that in your pathology report. They'll call it low risk GIST or a high risk GIST, etc. Okay, I have a couple more. I have a consult. Okay. But I wanted to get you guys' opinion. So this was a patient who a while ago had this MR, and it's only a pelvis MR. But what do you guys think about this lesion? It was like in the right lower quadrant and also extending kind of transspatially behind the psoas here.
Some kind of slow flow vascular malformation.
Excellent. So this is what I was thinking, like a lymphatic malformation. This did not, oh, here's the post contrast. Did not have any nodular enhancement within it. The wall kind of had thin enhancement. Any other thoughts?
Did
Okay.
it have enhancement?
The wall had enhancement.
I think some extremely cystic nerve sheath tumor.
Okay, good
Some-
thought. And I don't have the answer for this, by the way. So
Something thrombosed? How was T1 looking?
hold on, let me bring it to you. This is the T1 fat sat. It's not bright. There is a little bit of maybe T1 hyperintensity layering here. Okay. Move this for a sec. Okay. Then they come back months later. And I'll just show you the CT first so we can just cut to the chase. So the CT now looks like this. So, and on the initial one, we really didn't see any inkling of air within it. But the CT now looks like this. We've still got those parts that are the, cystic parts behind the psoas. And interestingly, there is this kind of tubular part coming off with calcification in the wall. And then it has air in it. And following the colon, what I thought was that this right colon here seemed to communicate with this. So I thought maybe the air was all from fistulization now with the colon. So my question is, do you guys still think this is a lymphangioma that's maybe fistulized with the colon? Or in retrospect, now that we see that there's this calcified wall here.
Is it like a mucocele?
Yeah, I guess that is the question. Do you think, have you guys ever seen a perforated mucocele that like, I guess if it's a retrocecal, like that, like basically went behind the psoas and into like the pelvic compartments like this before? And then the other question on the converse is, have you seen a lymphatic malformation that has like calcifications like this?
Not really the course, but like seen once like a mucocele that had like air, like after it got infected though, but not like the course that goes behind the psoas.
Yeah. I can show you the current MR as well. So you can see that the wall is much thicker now. There's air in it. We thought it was possibly communicating with that colon there. That's the like little tubular offshoot. And then, but then these are all the other parts here. So I don't know, I'll give you guys a follow-up. I guess like when I first saw it just on that like, months ago scan, I was like, okay, lymphangioma done. But now, I guess I have to think about like, I guess if it was retroperitoneal, why couldn't a mucocele, like same way, mucinous implants spread through the peritoneal cavity? If it was retroperitoneal, like why couldn't it spread in this retroperitoneal way? I don't know if you guys have any other comments. Tricky case. Okay, I'll give you guys some follow-up. And so this person has an aortic dissection. And there's an abdominal finding I just wanted to show to you guys. Residents, do you see anything? I'm going to show you the coronal. So this was the arterial phase. And then this is the venous face.
Yeah, there's a little concentric ring.
Concentric.
Jet. Oh, yeah, is it, sorry, rupture. There's like residual contrast around, like just below the renal takeoffs.
Oh, you mean in the like aortic aneurysm sac?
Yeah. So likely is that like a ruptured aneurysm? It's a lot of fluid in and around tracking along the aorta.
That was not, no. So, okay, actually that's a really good point. And I, basically this was an aortic repair, but what they did was they opened up the AAA, put a graft in and then closed up the AAA. So this, you're saying this fluid and stuff around the stent is actually normal.
Oh.
Yeah, but good observation. What about the bowel? Anything that you notice about the bowel?
It's a large bowel without really any ahaustral.
Yeah, there's this large bowel here that's ahaustral. It has like fecalized material in it. That's very suspicious. And basically the wall is not enhancing. Here, like if you, let me go back to the axials. Like if you look at this bowel wall over here, you can at least see enhancement, right? Whereas on this side, we're losing all enhancement of the wall here. So when you get that appearance, we've got this like bubbly fecalization, not normal stool kind of fecalization, ahaustral appearance, and then you're losing enhancement of the wall. You should be concerned about ischemia. So this patient actually ended up going to the OR and all of this colon was ischemic. So it becomes patulous, it becomes ahaustral, and then it starts losing that enhancement of the wall as well. Good, okay. Okay, this one is also for the residents. So we have a mass here. It's embodying the SMV. This is the pancreas. There's no pancreatic ductal dilation, but just to kind of, you know, it's sort of like centered in the pancreatic groove, but probably arising from the pancreatic head. So let's just say this mass came from the pancreas. What do you think this could be? Okay, you need to speak up. Sorry.
I was thinking about more of like adenocarcinoma of the pancreatic head could do that, and also maybe less likely cyst adenocarcinoma.
Okay, so good thoughts. So when we think about solid pancreatic masses, the vast majority are going to be adenocarcinoma. They aren't usually well circumscribed and large like this. If they're this big, it's usually, they're taking out vessels. They've already got peritoneal disease. They're not usually lobulated. They're more fibrotic infiltrating masses. So we're going to take adenocarcinoma as unlikely here. I haven't actually seen one that looked like this. And then you said cyst adenocarcinoma, good thought. It doesn't really look that cystic to me. If you suspect any cystic component, you should get an MRI. This was a solid mass. So what other solid masses of the pancreas do you know aside from adenocarcinoma?
Squamous.
Squamous. Okay, that's rare.
Colloid.
What'd you say?
Colloid carcinoma.
Okay, colloid carcinoma is a subtype of usually mucinous, like it usually arises in an IPMN. Good thought.
And just because it's like this homogeneous enhancement, it looks like, I know like an endocrine like carcinoid can also do that, but that's probably less likely also, given the location.
Excellent, excellent. So I would say probably like one of the biggest things that I would consider here is a large, probably non-functioning neuroendocrine tumor. So when you've got something that's pretty avidly enhancing, large like this, those neuroendocrines though, as they get larger, they can get necrotic, they can have calcifications, etc. But my primary top diagnosis probably would have been a neuroendocrine. And then attendings, anything else? that you might think about. I'm going to tell you it's not a neuroendocrine in the end.
Some kind of Castleman, unicentric.
Okay, good. I feel like
It's
our
enhancing
bringing up-
avidly.
Do you guys have a Castleman clinic?
No.
No. Okay, good. So,
Just
okay,
throwing out
residents,
zebras.
I have another clue for you. This guy had fat necrosis around his joints and bone infarcts around his joints because the lipase was elevated in his bloodstream. And he's an older male. Okay, anyone?
That's it.
What?
Glucagonoma.
No.
Still on the.
Anyone? Okay, this was an acinar cell carcinoma. So one of the board's questions is, these things actually produce lipase that enters your bloodstream. So they cause fat necrosis and bone infarcts at your joints. They tend to be in older males. They can be large and lobulated like this. They're very aggressive. So this one turned out to be an acinar cell carcinoma. And then a year later, or a year and a half later, this is what their liver looked like. So they actually did undergo a Whipple. You can see that the pancreas is here going to the small bowel. So normal pancreatic jejunectomy right here, but they've got extensive Mets. These Mets have a central scar. Like Victoria said, anything can have a central scar. They actually were pretty avidly arterially enhancing and had washout. So if I had seen that mass and then these liver Mets, I still would have said neuroendocrine until proven otherwise. That's much more common than acinar, but this was acinar. And somebody's chatting in. Anu says, great case. Cool. And Roopa says, good recap. I know. I think I might have even shown the Mets before, but yeah, I thought that was a nice pancreas case too. So just to summarize about solid pancreatic masses, 85% are adenocarcinoma. They're more infiltrative, highly aggressive masses, usually won't get this big. When we see bigger ones, we think about neuroendocrine. You can always do a dotatate scan to see, if there's any Mets. And then some rare ones would be like pancreatic lymphoma, acinar cell carcinoma, which is in usually older patients, more commonly males, and secrete lipase. And then I guess there are probably some other rare ones. You can get Mets to the pancreas, especially from RCC, etc. So great job. That's it for me.
Hey, Aarti, I have one quick case.
Awesome. And while we're waiting, happy Valentine's Day, everyone.
Same to you.
What?
Share screen.